Everybody to this evening's Pharmacy Sustainable Network event. This evening we're hearing from Nadia van Ginneken and Charlotte Condamine at Central Liverpool PCN, and they're going to tell us about a project they did supported by the Q Network around optimising deprescribing in SMRs in Central Liverpool PCN, and they're also going to be giving us a little insight to a whole range of other work that's going on in that part of the country. So thank you once again, Nadia and Charlotte, for doing this event for us tonight, and I'll hand over to you. Thank you.
Thank you very much. So I'll start with the presentation, then hand over to Charlotte, and then come back to me. So we've got basically a little bit about the background of our project when we did it, and then Charlotte will present sort of what we did for the project, and then I'll just tell you a little bit the context of where this project sits within other sustainability work that we're doing around Liverpool and Cheshire and Merseyside. Because I have a role as a GP in Vauxhall Health Centre, which is in just the north of the centre of Liverpool, as well as a sustainability lead with roles at PCN and ICB levels. So we did this project with 4 pharmacists within our PCN. So now, of course, it's not moving forward. Here we go. So we've just covered the overview a bit of what we're going to discuss. So I'm not going to spend too long on this, because I realise that many of you are very familiar with why we deprescribe, but just as an introduction of sort of the reasons we came up, why we wanted to do this project to encourage more deprescribing than was currently happening during the SMRs, is that we had noticed there's still lots of side effects in our patients, that there's still issues with concordance, and patients often say they don't take the medicines, but we're still encouraging them to continue even when they're not taking them. We know it decreases hospital admissions, increases quality of life. There's lots of evidence behind this. The waste is decreased when you deprescribe, the cost decreases, and the carbon footprint decreases. So it's just a win-win-win. It's one of the sort of top things practice can do to really impact on all 3 main areas of patient care: environmental improvements and cost reduction. So this slide just shows that 20 to 40% of all carbon emissions in the NHS are to do with medicines, and within primary care that sits at about 40% of all primary care emissions. And so the barriers to deprescribing is that often medicines are started but not reviewed, so they go on a repeat and then don't get taken off. Sometimes there's a lack of coordination, so one person might deprescribe and another might add it back in because of sort of guidelines or looking through other things. Or vice versa. Some clinicians just lack the confidence to look at polypharmacy and decide which are more priority medicines to keep on, and which can be discussed about removing, or in what sequence. And patients also have a reluctance sometimes because they feel they might need it, or please can you leave it on just in case. And sometimes when patients are talking to, maybe not to doctors, or to pharmacists, for example, there has been some patient fear, oh, well, the doctor gave it to me, or my doctor gave it to me. Sometimes we have that with different types of doctors. My initial doctor gave it to me, I don't want to change this. There's also really insufficient resources to deprescribe effectively, so perhaps not enough time for pharmacists or doctors to address that in their consultations. So how to deprescribe? I mean, I can let you go through these, I'm sure you're familiar with these. So obviously considering circumstances like frailty and patients' preferences, and using various criteria that you'll be familiar with, so stop-start, the anticholinergic burden and so on. also stopping one medicine at a time, which is sometimes more difficult, because then that means more repeat visits, but with an overall benefit, even if there are multiple visits or contacts, and then down titrate if necessary, always following up a patient once they've stopped a drug, and then sort of being realistic about the time frame. I think that's something our project highlighted, that it does take a little bit more time. Writing a comprehensive plan, or at least discussing it with them, and having consistency with one practitioner, so that there isn't that issue of different opinions, and one practitioner probably has in their head a sequence of when to stop each medicine in sequence. So, and then thinking of what's appropriate polypharmacy and what are the inappropriate medicines as well, and how to substitute it with maybe alternatives like lifestyle, pulmonary rehab, and so on, that could be equally, if not more, effective. So we've chosen the multimorbid patients, those who have polypharmacy have most benefit from deprescribing, the elderly frail, who are more prone to falls, the housebound, same, and end of life, many medicines that don't need to be there, like statins, and vulnerable patients who often are chaotic in how they take their medicines, to try and avoid them having too many sort of medicines that they don't take properly, and those with poor renal and hepatic function. I'm not going to read through all of these. We will share our slides, but just an example of some of the medicines on the Stop Frail list, which are encouraged to be deprescribed if symptoms are not too bad, or because they're no longer really all that beneficial in those categories of people that we mentioned, especially end of life and those who are very frail. Okay, so I'll hand over to Charlotte now, and I'll move the slides along, Charlotte, as you need.
I think I'm actually able to move them myself. Let's have a look.
Oh, okay.
Yes, look at this. Amazing.
Oh, good.
Right. Okay.
Charlotte,
so...
it's only your view that you can change. Nadia needs to change them for you, just to let you know.
Thank you, okay. So thank you for your help, Nadia. Then. Right. Okay. So I'm Charlotte. I am a clinical pharmacist at Central PCN. I've been working with that PCN for the last 2 years, 4 years in primary care. So I'm just going to talk to you through the project we did, which started in December 2023, finished in August 2024, based on deprescribing in polypharmacy SMRs. Next slide, please, Nadia. So look, nice. Okay, so our objectives, as discussed, were to conduct SMRs, polypharmacy SMRs, with a strong focus on deprescribing. So we focused on patients who were on 10 or more repeat medication, and focused on medication that was not used, not effective anymore. We still find duplicated items sometimes. We've also checked potentially harmful medications, medication that's increased risk of falls, ACB scores, addiction tolerance, opioids, for example, as well. Also unnecessary medication, or things that we can't prescribe anymore on prescriptions, like certain creams, toothpaste, rebufations, and obviously the ones causing side effects. Next slide, please. Nice. So yes, as the project was funded by the Q Network, with the £1,000, we costed this as an equivalent to approximately 80 SMRs by 3 Band 7 pharmacists. We also had 1 senior pharmacist to help designing the project and supervise, and 2 GPs providing some academic supervisions. The 3 pharmacists, so we did conduct our SMRs as usual, with compliance, side effects, monitoring, understand of further medication, question queries, ACB scores, and then obviously deprescribing. We've used the tools that Nadia discussed before, Stop Start, and the rest of them. And also we did compare our deprescribing rates to 2 other pharmacists that did from the same team, so they have the same style than us as well. who conducted standard SMRs in the same time period. In total, we reviewed 81 patients from our 5 practices. 59% of them were female. Average age was 65. In our PCN, we have 120,000 patients. 4% of them are on 10+ medication. We have a lot of students. Next slide. So our cohort included patients who were on between 10 and 25 items. 36% of those were on variable repeats, which means that the variable is to order when needed, which is not always the case as well. So we did review 1,191 items altogether. So we did stop 37 items of 81 patients. Compared to the control group, that's quite a bit. We also were able to reduce 32 of them, so either it was quantity or the strength of the item, compared to 8 in the control group. The medication that we stopped, the majority of them, well, the one that we stopped the most were, for example, laxatives, creams, vitamin supplements, but also antidepressants, for example, or even PPIs or H2 antagonists and more. We also started for medication because it did happen. 60 patients in our cohorts reported side effects. Also, our ACB score had an average of 3.7. We were able to reduce only 3 patients, like the ACB score of 3 patients only. Obviously, it's because plenty of the medication we had there do not have an ACB score. We checked the reduction in carbon footprint. For that, we used the MCF classifier, which is the Medicine Carbon Footprint Formulary. Very interesting, very eye-opening as well. We did not have a carbon rating for all of the items that we did prescribed, only 22 of them. However, 72% of those 22 were medium to high carbon footprint. Regarding the cost saving, so it took us in an average of 7 minutes longer to do the Deprescribing focus SMRs. Reviews lasted between 20 and 101 minutes. The Deprescribing focus SMR saved £914 more than the standard SMRs. Even if we take into account the extra 7 minutes, it was still a cost saving. So if we were applying that focus onto the polypharmacies within the PCN, we would it would save us between 36,000 and 55,000 per year. So achievements with this project so far. So we won sustainability awards. We've also been speaking to the chief pharmacist at the ICB. We've discussed the model with the prescribing pathway team. We also did quite a few presentations within different primary care forums. Top tips. So don't be afraid to represcribe. The way I see it with my patients, I always tell them it's a trial. We try to stop. If you're not happy with it, we start again. I think it's a very good way as well to empower the patient to really take ownership of what they're taking and be interested in what they're taking as well. The more they know, the more they will be able to manage. Also involve colleagues, involve GPs, involve the prescribing team, involve the receptionist. Do you actually really need this medication? Are you just reordering the whole bit? Do you know what you're taking? Do you want to have a discussion with the pharmacist about it? Just talk about it. Promote the wins, so including the cost and environmental. Also get your pre-reg and your student to do it as a quality improvement project. It's very interesting. The challenges, time. It is a lot of time to do the auditing. It's obviously a lot of time to gain the trust of the patient. Before doing the prescribing bit, we need to do all the other bit as well. So sometimes we work a lot under pressure. We don't always have time to get to that bit of the deprescribing, but it's always good to ask, do you use everything? Are you sure? Do you really need this? And there's always possibility for another conversation about it. So in summary, this study has shown a lot of positive impact from the prescribing, whether it's for the patients, for the budget, and for the environment. It was too short. I think the not being able to follow up patients to see their feedback, well, we were able, obviously, but not within the project. So to see the impact, to see the actually represcribing rates, yeah, impact on quality of life and just feedback from patients. That would have been interesting to put that in there. We've shown that it's good to invest resources with the aim of patients using only what they need with even minimal side effects. And it was all that refocusing was a very minimal added cost compared to the large cost savings and carbon savings we did as well. Next step, so just spread the words, get everyone to deprescribe, and yes, so rolling that out across all the team and beyond.
You're still muted, Nadia.
Sorry. We're thinking, so working to incorporating it in the deprescribing strategy is across the ICB potentially as well. But with the ICB being rejigged at the moment, we're a little bit on hold. But yeah, so and then I think because there were just four people trained up within the pharmacy team, which Charlotte, there used to be 12 because our PCN has also changed size since this project, but there's still 6 within our team. Yes. And some different, so you know, is to just maintain what the learning has been and encourage the others to use it too, which we're still in the process of doing. And so I think we've got some resources here. I'll sort of I'll let Noala share these slides, you know, into which are the deprescribing guidelines, but also the tools to use during these reviews, and some very good other webinars apart from this one online for online learning, and which patient resources you can share with people to help them make that decision that actually it is okay to stop medicines as well as start them. So I don't know how we want to do with questions. Shall I just briefly give the context of the rest, and then we're happy to take questions? Is that okay, Noala?
Yeah, that's fine, Nadia.
Okay. So what else we're doing? So within Cheshire and Merseyside, we had at ICB level, we'd written up a 10-point green plan about 4 years ago, and have been following various bits. So this deprescribing project was one of those where we got some funding, you know, to do that specifically, to allow us that time to do all the auditing. But there's various other things we've done too. So the plan has recently been refreshed and aligned with the ICB green plan. And so other things that we're doing across the ICB include projects on active travel, on biodiversity. We're encouraging different gardens to be created within health centres. So one is in ours, and then across the PCN, and also in some of the other ICB areas across Cheshire and Merseyside. We've had some funding from the ICB last year to fund 10 projects across Cheshire and Merseyside. Some other ones are around sustainable period management, so using reusable products to help in a deprived area of Warrington, for example, so to help with costs for those people, and obviously better environmental impact. And then we've had a very successful project in North Liverpool on a low-carb diet program run by a team of health coaches and a GP, similar to David Unwin's project. We've had a project in Cheshire on rationalising annual blood tests so that people don't keep getting it in dribs and drabs, but that they've got a system properly in place so that people are subjected just to one lot of annual blood tests. And various asthma and inhaler initiatives that started sort of before the national guidelines came out, but have, continued and now promoting the asthma guidelines. And so some of the other things that we're working on currently, in addition to those funded projects, are looking at social prescribing directory of different activities across the ICB. We're looking at sort of linking sustainability to sort of health equity and social equity. So the anchor charter across Cheshire and Merseyside is for the anchor institutions, meaning those that are important within communities, to sort of practice what they preach, show that they are, for example, employing people in above the minimum wage. That's one of the aspects, and then also encouraging some community participation and work across the community and linkages. So the first anchor practice was Eric Moore Partnership in Warrington, and we've set up 2 anchor PCNs, so as a grouping of practices in Liverpool. So ours is set up, and also this Picton Primary Care Network. We've done other work on asthma inhalers in the last few years called Greener Breaths, trying to address overuse, and also Medicines Waste campaign, which was initially the Dorset, modelled on the Dorset campaign. And then across Cheshire, there have been various other initiatives, specifically from individual practices and PCNs. So within my role at the PCN level, so this deprescribing was one of them. We've also looked at air quality and put air quality monitors with some geography students. We do medical student teaching, where we offer them some activities over 6 weeks. We have got one practice who's taken part. Oops, have my slides just disappeared? No. Wait,
no,
hang on, I clicked something. I clicked something and they disappeared. There they are. One practice who've done the Green Impact for Health Toolkit and green banking, and then the greener spaces I was talking about. The other things I talked about already: anchor institution, prevention pledge. So that's a bit of a whiz-top tour. So I'll stop speaking now and happy to take any questions.
Great, thank you so much, Nadia and Charlotte. Do you want to just stop sharing your slides, Nadia, and we can see if there's any questions? I'm just putting links in the chat as we go along, just because you were talking about air pollution. It is Clean Air Day tomorrow, in fact, so I'm going to put a link into that. So does anybody have any questions for Charlotte or Nadia? Please just put your hand up or just unmute yourself and ask a question, or feel free to put it in the chat. So Patrick Heaton's asking, has any of the funding come from outside of the NHS? So yeah, it'd be good to just outline, Nadia, where the funding came from, because it was fairly limited, your funding, wasn't it, which kind of limited what you were able to do.
Yes, absolutely. So this Q Network funding is from the Health Foundation. So it's linked in partnership, but it's not exclusively. The Health Foundation gets also some private donations and government support. So, and it was only £1,000. So actually we were approached by them pretty much saying, you know, do you have a project you want to do? And it wasn't exclusively for environmental projects or greener NHS projects. It was for anything to show, what was the title? Just anything to show good practice in general practice. or innovation. So we just got the £1,000 basically from a phone call, didn't even have to submit anything, and then just started the project. So it was easy money, but it sort of slightly by chance. The other money that we've got for those ICB projects, so there's the ICB projects I was talking about, that came from the ICB. So we went to the ICB saying, you know, you need to give us some funding. And they said, well, either we can fund you to be a lead, or we can give you this. Well, we said, actually, we won't do that. We just want to use it for projects. So we've done it that way. But it meant that we're getting paid just a real minimal, a nominal amount, just to show that we've been supporting this project. There's 5 of us from Greener Practice from Cheshire and Merseyside who are supporting those projects, those 10 projects. And then other funding that we've had has been through sort of Health Innovation Fund. So that's NHS linked as well. I have looked at private funding from elsewhere because that seems like there would be more options there. But I haven't really had the time to look into it properly, but I also haven't found anything that where we are eligible for it. With the green spaces funding, I got 14,000 for the green space funding through a university project who was supporting community projects. And again, that's sort of, it's just keeping an eye on what funding projects there are and applying for them. Okay, National
great.
Lottery funding. Yeah, Patrick's saying, do you feel there's still full buy-in from GP practices in terms of SMRs? I was recently told by one of our practices they don't do these anymore as they are too time consuming. Okay. So that's another question. And then the National Lottery funding is a question mark. Yeah, I haven't applied for National Lottery funding, but I think the Greener Practice directors had thought of applying for a bigger thing from National Lottery, but we haven't got around to doing that yet. Have you had any experience with it? Are you, is Patrick able to unmute?
Yeah,
oh, yeah.
I am. Yeah, sorry. Yeah. No, it's just, the reason I asked is because part of my role involves it's overprescribing and opioids in chronic pain, and one of the things that I'm trying to get funded is something called pain cafes, which are peer support for patients in terms of chronic pain. And I'm really struggling to get any sort of funding through the normal routes through the ICB, etc. And so I'm now exploring other routes, and I did notice that another area had managed to get some money through the National Lottery to do their version of pain cafes. So it was something that I was considering now, whereas traditionally I wouldn't have even thought of it. But I don't know how easy it is to get money through the National Lottery, but needs must, I suppose, really.
Yeah, I think I think it's quite competitive, but that sounds like a brilliant idea. I'm quite interested in chronic pain myself, so if it were multi-site and you wanted to I don't know, see what works and what they stipulate, because I haven't looked at all their stipulations, but that sounds like a good place to approach for that sort of thing, because it is in the patient's interest, and I think they're keen on that, aren't they?
Indeed.
Yeah. And the other part of your question, Charlotte, do you want to answer from the pharmacist point of view, or shall I answer it? You can, go ahead.
Well, from I have not heard of that. Actually, we're still doing quite a bit of SMR, and still part, I think, of our just strong part of our job. But I don't know whether you've heard anything, Nadia.
Yeah, I know that there's across the GP community there are some different views, that some GPs feel that GPs can just review the medical records without calling the patient, and it'll take them sort of 5 minutes to just list what everyone's on and checking they're on the right thing. And they don't see why it should take 20 minutes. And that at the end of the 20 minutes, nothing more is achieved. I suppose for me, like, the benefit of the pharmacist is they have more time to do a bit of deprescribing and thorough checking of, you know, interactions and things like that, whereas GPs never do that really. So and I know some practices who have, you know, employed, for example, a retired GP to just get through a whole lot of that is actually happening, Charlotte, in our practice as well, in addition to the SMRs. But those are for not the SMR reviews. Actually, they're for the other medication reviews under 10.
Okay.
You know, under 10 prescriptions, repeat prescriptions. So I don't know what I'm happy to hear from anyone if they want to unmute or raise their hand, whether that's an issue in their area that pharmacists are not being given SMRs to do anymore.
I think the problem came when it just became part of the PCNs, and there wasn't the same incentivization in terms of the previous scheme, and it kind of, I think in part it just fell off radars really, because obviously there was lots of concentration on it at one point, and then it just kind of to some degree fizzled out, and so some people carried on doing it and we carried on sort of pushing it very strongly, but other people seem to have come to the conclusion that they didn't really think it was part of what they were supposed to be doing anymore. And it like you say, it's very complicated because different people feel different things about this, unfortunately.
Yeah.
There's some questions in the chat, Nadia, about the training for the pharmacy team, which is actually one of the questions that I had written down as well. So, because you said, I think you used Band 7 pharmacists to do this work. So did they feel confident to do this prescribing, or did they feel like they needed some training or education first? Kind of what was the approach there?
So, yes. So I think it really depends on how senior was the pharmacist as well. So the 3 pharmacists that participated there, we were quite new in primary care as well. So it took us a little bit to learn how to do that. So what we did is use the tools that we've all read, and furthermore share, ask for advice. Anything that I was not really sure of, I would always run it by a GP, and obviously follow up with the patient. But there's not really like some specific training that we just did, like in the team meetings, just doing it all together and going through what we found.
Yeah.
Yeah, it was sort of felt that, you know, it was already covered in, you know, the knowledge is already covered in a pharmacist's knowledge base. But it was just a question of emphasizing which bits to bring into the review. So it wasn't intensive on training at all. I think you guys had a meeting together, and then you attended the regular meetings we had every 2 months during the 6 months of the project, and that was it. So minimal training, just applying.
Yes.
And did you find, Charlotte, that there were particular drugs that were easier to deprescribe than others, or others that were particularly challenging?
Yeah, of course. I think what we actually found was very interesting. Like, the more medication someone has, the harder it is to deprescribe. Usually the person really becomes fully dependent on their medication. It's easier to deprescribe on someone who has less medication. I really thought at the beginning that by tackling a cohort of people with a lot, we would have a lot to deprescribe, but no, people are very territorial. Well, obviously opioids are very difficult. All gabapentinoids as well are complicated to deprescribe. Amitriptyline, that's a huge no as well. But some other ones were just easier, and it was a lot of problems are just logistic of over requesting medication, whether it's the pharmacy or the patient who just does not understand what they're taking, or that they can just order what they need as well. So it was understanding of the system, understanding of what they're taking.
Yeah. Okay. So that's
factors.
two issues really, isn't it? The kind of the system and the patient not being able to fight against the system to not get the repeats every month.
Yes.
And then the kind of the clinical aspects as well. So Helen Kingston from Froome is saying they have local personalised care training that helps embed confidence and practice of shared decision making for the many situations where there are no easy answers. And I think that sort of person-centred shared decision making approach is absolutely critical to this, isn't it? And can completely change the consultation from the sort of traditional approach. So
does Helen want to say something a bit more about that? Actually, be interested to hear. Yeah.
Well, Naomi and I, Naomi's on this call as well, have both been doing that, and we're trying to get cohorts of clinicians trained. But I think a lot of deprescribing doesn't fit a neat category, and it is about reflecting the patient's priorities, their level of frailty, what's most important to them, and weighing up contradictory aspects of things, isn't it? And working with them. If you work with them, you can make more progress than if you're seen as threatening of stopping something that they're holding on to. So, yeah.
And I mean, how do you find working within that? You know, the shared decision making is also within the team, really, is getting other clinician support for this approach, and you know, do clinicians read back and read your entries to know not to re-prescribe these things if they're not?
I think if you're working well with the patient,
yeah,
then the patient isn't asking for those things back. It needs to be their decision, you know, with any medication, it needs to be their decision with you rather than just stopping things. And then you need to make sure you've coded the beta blocker contraindicated, the ACE not tolerated, or whatever it is, because I think often when you talk to patients, they've had side effects, but it hasn't been recorded in a clear way, or they've got postural hypertension, and it's clearly inappropriate to be over medicating their blood pressure. So it's making sure you've coded that so that that's also on the record for other clinicians coming back to that. But yeah, I think if we work together, that works well.
I think the coding is important, because not everyone actually is going to go through what has been done before. What Patrick is saying regarding opioids, for example, is a big example of we are able suddenly to deprescribe someone's cocodamol, and then a month after someone just doubled the quantity of it, because even if we had a clear plan and we wrote it down on the consultations, no one's going to really read it. So that we are yet to find a way for that not to happen.
Yeah, that's right. And I mean, I think one of the issues I find is that, you know, if sometimes patients are on that many medications. So that's the other thing that the project threw up, is that, you know, if they're on about 10 to 15, patients can retain what they're on and what the reasons are for each medication. But we started with patients over 20 medicines. And actually it was impossible to deprescribe on them, because they're like, you know, all these specialists have told me to take all this stuff, and I just don't, that they were the most resistant to change. They're like, this is the only way I've found some sort of stability. By the time someone gets to more than 20, it's a very hard group of patients. So then we expanded the project to the more than 10, but very much, you know, in lines with working with the patient, then it became easier. I don't know what Charlotte feels. I think just an extra 7 minutes to have those discussions and to reorientate some of the other 20 minutes is actually not too bad in terms of extra length of time. But yeah, whether that would be possible across, you know, it has the problem about the decisions on how long to spend on SMRs is a locally made decision. So it's not something that everyone has to negotiate within their own PCN or local structure.
So your experience on this project, Nadia and Charlotte, has that sort of led you to, I guess, provide information to patients about their routine medication reviews and routine SMRs? Because I always think if you sort of, patients coming in for medication reviews often don't really know what they're coming in for. They don't know what a medication review is. They don't know what the point of it is. So you spend the first 5 minutes kind of explaining it, and actually they haven't thought about anything. So are you doing anything around sort of proactively informing patients so that they can come along a bit more ready to be a partner in that kind of consultation, as opposed to just sort of being told what to do?
Yeah, I think, Charlotte, there is a text message that gets sent out, isn't there?
Some people use it, some people don't. I do a lot of just, we can start the conversation and then we can have the week after. Or I usually spend a lot of time with my patients. I think that the beginning we have really the introduction, and then we can get in depth in many things. So people are usually quite happy to discuss. And if I feel that I've not really gone in depth with someone and I need to go more, I can always offer like another call in a month's time, and they know who they're going to speak with, they know what they're going to talk about, and you give them time to really think about it a little bit more, because so many times people just take the meds without really thinking why, what for. So you just start with putting a little idea that they will be able to discuss afterwards.
So do you think from doing this project, Charlotte, that you're kind of more inclined to do deprescribing now routinely without thinking about it compared to previously?
Way more. So now when I start something, I always tell them what's going to happen after. So when are they expected to have results, what to do if there's no results, monitoring and reviews as well, because it's just, instead of just putting another thing in the box, I always make them understand that we can always stop it, or there's other option if they are not happy with it as well. So it's, yes, definitely way more focus on that.
Yeah, great. So thank you.
I think there's a role also with GPs, because the way we're working within our team, and I've been encouraging GPs to work with the pharmacists, is that we pick these things up opportunistically. And if people come in with vague symptoms, to remind doctors to really think about the medication. Is it side effects? What should we be doing? And falls, definitely an opportunity for deprescribing, that sort of number one thing. So, and then if we're planting the seeds opportunistically at those times of either crisis or mini crisis, then we have a follow-up, we organize a follow-up with the pharmacist, and it tends to work quite well, I think. So that we've been working in that way as well, referring in for more in-depth SMRs for deprescribing. Yeah.
Thank you. So Patrick's put a link in the chat to useful resources for SMRs that can be shared with patients. So thank you for that, Patrick. I just want to make sure we cover all the questions. Somebody is asking, Julie's asking about where she could find more information on the Optimizing Blood Test project, Nadia.
Yeah. So there is apparently a function within EMIS. I don't know if you work with EMIS or not, that you can activate to do that. But what I can do is, if you're interested, there's my email address on the slides, and just email me and I can put you in touch with those who are doing that project, because they'll have more insights. They've been doing the audit. They haven't quite finished going through it, but if you want a sort of template for how to do that, we'll have one fairly soon. I think the Greener Practice Toolkit that's going to come out in the next week or two, hopefully now, might already have a template. So Greener Practice are putting together, ready to go projects where they explain exactly, what you need to do, who you need to do it with, if you need funding or not, and how to, which websites to use for doing things. So it's going to be quite a good toolkit that practices can buy into, or PCNs. But anyway, so that would be it's not very expensive, but if you want me to put you in touch with the project who's currently doing it, I can do that too.
Great, thank you, Nadia.
Yeah.
Okay, I don't think there's any more questions in the chat. There was a few entries about funding. So somebody said Climate Action Fund is a possibility, but then somebody said they don't fund mainstream NHS work. So that thing of people are just kind of looking around for funding for projects. I mean, the Q Foundation, the Q projects as part of the Health Foundation is a good source. They sort of periodically release funding for around sort of quality improvement and health related projects. So they're worth keeping an eye on as well.
So yeah, the Q Foundation ones. So there's £1,000 ones that we got access to, but don't know which one you got, Noala. But they told us that the next step, if that works out, is you can go for a 3,000 pot and a 10,000 pot. But I think the innovation stream somehow in Liverpool sort of fizzled out. They didn't get funding beyond that. So I think it's just a question of keeping an eye out for different pots.
Yeah, absolutely. I'll pop the link for the Q Foundation in the chat box. The money that we got was an annual one, but they're actually taking a break and haven't released any money this year because they're sort of reviewing the whole sort of project. That was the Q Awards, and it was, you could get up to £40,000, but that's not available this year, but maybe next year.
Okay. Can I just ask Patrick then, because you put the link to that leaflet for patients, but do you tend to send that to patients before they come, or in what context do you use that, if at all?
Right, we have promoted it, which obviously is the limit of our power, really, because I work for the ICB. We have promoted it across West Yorkshire as a really useful thing to do, to try and go through some of the concepts with patients so that they can start thinking about what they might want to talk about within the SMRs, so they're kind of pre-triggered to think about some of the questions that are likely to come up. And the task and finish group that did the work, which was a follow-on from the overprescribing report, the national overprescribing report. They developed the leaflet plus videos, and there's a video both explaining to patients about what SMRs. There's also a video explaining to other staff members what SMRs are, and the leaflets come in various other languages as well. But yeah, the aim is really for them to go prior to the with the invitation to the SMR, really, so that they can have a look at it and see what they think, and hopefully they'll get something more positive out of the SMR, because they are already triggered to be thinking about things. So that was certainly the aim of that project.
Okay, that's interesting. Yeah, we have, we're in a very deprived area of Liverpool. I think it's the third most deprived ward in the country, and we've got something like 15 or 20% illiteracy, and quite a few people who are literate, but only just. So, I'll have a look at it in more detail. I think videos are quite good for our populations, and very short amount of text, because most just can't take on text. So yeah, but it would be, I will definitely have a look at it, because maybe we can incorporate it better and send text messages. I have to say, our population don't like receiving text messages from our practice at all, so we've been told to limit that massively in terms of promoting anything before they come in to see us. But every practice is a bit different, every area is different.
I think if they'd had the choice and more time and more money, they might have gone out on to do more along the lines of QR coded things, because one of the projects in terms of inhaler technique and asthma, which was done in a Mid Yorkshire hospital, was very much about understanding that patients can't necessarily read their own language, and therefore you have a QR code which goes to a video of somebody talking to them and explaining the inhaler technique in their own language. And I think it would have been nice potentially to do something similar in terms of the SMRs as well. I think that could work quite well, but I think, like a lot of these things, you do so much and then you get to the point where you can't go on, and I think that's kind of where they got to, really.
I mean, the Dorset Medicines Waste campaign it's not been specifically focused on SMRs, but it has been focused on inappropriate medication and inappropriate prescribing, over prescribing, and so on. And they have some good videos that we've sort of taken over for our ICB, and there's also, I think there's some good I think there's a link in the resources to how to get, there's from Yorkshire as well, waiting room videos on this as well. So those resources are there. I think Honey Smith from Greener Practice had developed those.
Yeah, I was going to say the waiting room videos are definitely on the Greener Practice website, and I'll put the NHS Dorset link into the chat. Okay, I'm kind of conscious of time. It doesn't look like there's any more questions in the chat. Thank you so much, Nadia and Charlotte, for coming along this evening and sharing the great work that you're doing. Nadia, did you say you were happy to share the slides?
Yes, very happy to share. I think we're both happy to share these,
Okay, I'll kind of make them into a PDF and sort of get those out onto the network. I'm just kind of showing you there the QR code for the Pharmacy Sustainability Network. If you haven't joined our network, please do join. Everybody is welcome. It's not just for pharmacy people, and lots of information on there around sort of medicines related stuff, pharma pollution, everything really to do with medicines. Our next event will be in September, October time. We haven't got a date just yet, but I am finalising that at the moment. We're going to be hearing from a team in Manchester who are implementing the Royal Pharmaceutical Society Greener Pharmacy Toolkit across the acute trusts, and also the Medicines Management team have developed a sustainable pharmacy guide. So we'll be hearing from them in the autumn. So watch this space for more information. So just left for me to say thank you very much, everybody, for coming along this evening. We will be posting a recording of this on our YouTube channel. Thank you so much, Charlotte and Nadia, and have a good evening, everybody. Thank you so much.